So we have some time for some discussions with Dr. Van Sta, if anybody wants to. I'll start out with a general question. It seems that you have so many good things going in that you're leveraging the EHR system. The hybrid is a minimal. I'm sure that there are probably, 10 or 20 fields you added for the statin at the most. Yeah. Wouldn't it be logical that that the government would just pay the docs for the extra time it takes to do this to be an incentive? And that might reduce a lot of the refusals for them.
Yes, clearly we've seen that in the UK with something called quality audit framework, where GPs were paid to collect additional data on patients with diabetes, and basically what you've seen is the rate of recording went up quite a bit, and the government want to use that to measure the outcomes and how well performance was. So yes, the idea is if we can incentivize either monetary or by having the professional education points, a lot to that. Yes, I think there's an issue, and there's clearly would be extremely helpful, because I think the clinicians we spoke to they were more than willing to do it. The biggest problem for them was all the paperwork they need to do, all the extra work we need to do in order to recruit patients, and they were busy. Like in the COPD study, the challenge there is the waiting room is full, and then they have to talk to a patient in length through the consent form, through everything that's happening. So having simpler models of consent or other models of consent procedure, I think also would be extremely useful in that.
And just one more structural question. You have 8% now in the CPRD, and I think it's primarily based in England, and you're going to expand this to Scotland, Northern Ireland, and Wales as well, and go more than 8%. Is that right?
Now, currently the database is across the UK, so Scotland to Northern Ireland. A lot of the linkages we're currently doing are only in England, and we're trying to have a lot more practices in England specifically. But in essence, this system can be used in Scotland as well. And the idea is that we get more practices and also involved in kind of more clinical trials. Because, like I said, the vast majority of clinicians are not doing research at the moment, which I really think is a loss. Because how can we practice evidence-based medicine when clinicians are not actually engaged in generating the evidence?
Ralph?
Struck by your remark that the midlife crisis every time you thought about maybe I can speak loud. I was very distressed to hear that you were driven to a midlife crisis every time you thought about confounding my indication in observational studies. I was driven not to a crisis, but I was certainly discouraged to see that you had roughly about 5% participation in your statin trial from among the practitioners, from among the patients in a single practice that you referred to. And it's not despairing, but it's not encouraging either. And I wonder how you think about this trade-off between that you're dealing with as you have this very low participation rate in your trials and its ultimate generalizability, and whether you would have confidence in the results at the end, that the findings you have would really help to inform the way in which we manage patients in your health system more broadly.
Yeah, that's a very good question. I mean, to one level, to some extent, not completely, you can measure the patients enrolled in the clinical trial to those who are not. So we're able to measure that, which of course will not give you the complete picture. But ultimately, I think we need to go to a situation where we recruit more patients, where it's almost routine practice to enroll patients in a trial. If you get a statin and we don't know which type of statin is better, it would be very rational to say we randomize you to that. And so I think that's where ultimately the answer lies, to make those studies easier to do, and then hopefully we can increase the participation rate.
Chris Granger from Duke. Congratulations and thanks for sharing that. And of course, you have major advantages in the United Kingdom compared to the United States. So two questions that maybe you've begun to think about is, have you thought about kind of how to deal with challenges of going outside of the United Kingdom, for example, in international trials, using what you're doing as a foundation? And do you think there's any hope in the United States, where we have such a fragmented system to be doing this, and any advice on how to embark on that?
Yes, I mean, UK has a very nice and beautiful system on that. But other countries are also developing and have very nice electronic healthcare systems as well. And I think like Scandinavia, Holland and other countries where they have very nice, interesting data. It's a matter of kind of almost the final touch is getting people in agreement that yes, we can also use those data for clinical trials, and technically it's possible. It is more that we haven't done it a lot, and it's going through that motion of accepting, yeah, we need to do those studies. And I think the same applies to the US. I think there are very nice systems here as well, where you can, if you are able to link to other data sets, you can get a very complete picture of what's happening to the patient. So probably my advice is not to think, oh, you can change everything in the US, but it's probably like mentioned by previous speakers to have examples of how it can work, and that will then lead to other people taking it up and spreading the good news in a way.
Let me ask a question about the part of the governance structure. How do you decide what questions are asked, and if a physician wants to ask a question specifically, do you develop a steering committee for each trial? Is there a data safety monitoring committee on top of that? Is it all managed within the MHRA, or are they going to be medical societies? How do they interact and generate ideas for studies?
I mean, what we currently focused on a lot of kind of getting the studies, the technical infrastructure in place, and I think we've reached a stage where we can say, yes, we have that, and we are enrolling. The whole idea is that in the future, I mean, any trial will need a data steering committee and trial steering committee. That infrastructure needs to be in place, and it often will be an academic researcher who would take the lead, but hopefully clinicians can feed into that, into setting the research agenda. And I have to say, one of the research funders, the HTA, the Health Technology Assessment, they're really interested in this study. So the hope is, of course, that they will then generate more studies where clinicians, in collaboration with academic researchers, can then conduct those studies. And we at CPD, we can then provide basically the data and the systems to kind of to analyze the results.
Well, if there are no further questions, I want to thank you for the great keynote presentation. Thank you, Mr. Stahl.